Hello, my name is Christopher Zaw-Mon. I'm one of the trauma and general surgeons here at Lutheran Medical Center. Today I'd like to present to you REBOA. This is a device that many level 1 trauma centers are now using for resuscitation of patients in hemorrhagic traumatic shock. This is the didactic portion of the presentation, to be followed by a hands-on learning lecture with a model showing how to place the REBOA device. During this presentation, I'm going to give you some background on what the REBOA device is, the indications for using the REBOA device, and some of the articles and literature that are out there showing the utility of the REBOA device. REBOA stands for resuscitative endovascular balloon occlusion of the aorta. This device allows for placement of a catheter that is placed into the femoral artery, threaded up into the aorta with a balloon that allows for occlusion of the aorta. And this is used in patients that are in hemorrhagic shock, where it provides for temporary management of the hemorrhaging. Again, this is a temporary measure to allow for continued resuscitation in the emergency department, in the trauma bay, in order to allow for eventual surgical definitive care in order to stop the bleeding. The benefits of this device are that this is something that can be performed with someone that doesn't have vascular practice or expertise, and this can be done in the emergency department, allowing for temporary control until a surgeon is able to take the patient to the operating room to get definitive control. A couple of articles. I thought that these two articles were beneficial for what a REBOA device is, and it's shown some successes in terms of mortality. These articles, one by JAMA and the other one by the AAST. The AAST is a prospective multi-center study that in level 1 trauma centers that's shown some impressive mortality results, up to 20% in patients that might have gone for a resuscitative thoracotomy. This device has been shown to be easily employed by providers with some practice, but not requiring any specific surgical skills, and it is allowed for not only improved mortality, but also neurologic outcome. So the procedural steps to the REBOA device. You're going to access the femoral artery as you would with any femoral art line, using an 18 gauge art line or a 5 French micro puncture kit, or you can go straight to the 7 French introducer sheath. The 7 French introducer sheath will be demonstrated at the learning module of this presentation, the hands-on module with the model. After you've gained access to the femoral artery, you will determine the zone and placement of the balloon. And this is going to depend on the type of injury that you're suspecting the patient has, where the patient is bleeding from. And we'll go over the zones as well as the indications for where the placement of the balloon should be. After you've determined the zone and placement of the balloon catheter, you will advance the catheter into the common femoral artery, into the aorta. You will then inflate the balloon. Once you inflate the balloon, watching the arterial waveform, you will notice a fairly marked difference in terms of the blood pressure. From my experience, once I inflate the balloon, I immediately see an increase in the patient's pressure as it responds to occlusion of the aorta and increased blood pressure to the upper torso and extremities. Finally, you want to secure the catheter to the patient, and then the clock is ticking because this is only a temporary measure, and you then need to obtain surgical or definitive control of the bleeding process. This is the Joint Trauma System Clinical Practice Guidelines. This gives an idea as to the indications for when you'd be using the device. This is a work in progress. This is still an early procedure and device in terms of its utilization, and right now these are kind of the rough guidelines in terms of determining the zones as well as which patients you should be placing the REBOA device into. For blunt trauma, it's fairly straightforward. Any patient with severe chest injury, the REBOA is not indicated. Patients that are in extremis with severe chest injury, you would continue with ATLS protocols, and the patient would require definitive control, possibly with a thoracotomy. However, for other injuries, such as bleeding in the abdomen, if you have a positive FAST scan and the patient is hemodynamically unstable, those are patients that you would consider placing the REBOA, and you would place that in zone 1. Again, we'll go over the zones in a moment. Pelvic fractures. This, I think, is one of the best indications and utilizations for the REBOA. I've used these on patients with exsanguinating pelvic injuries where we don't have time. We're calling in the IR team. Patient may have a binder in, but the patient continues to lose blood. This is an excellent procedure or device to obtain control of bleeding and allow for time for other services to come in and perform definitive procedures to stop bleeding in the pelvis. So any blunt abdominal trauma to the abdomen or pelvis with hemorrhagic shock, the REBOA is an excellent device to use in order to obtain temporary stabilization of their hemodynamic status. For traumatic injuries, injuries to the neck and chest, again, these are not patients that you would consider using the REBOA. These are patients, at least at this time, that you would want definitive control and possibly take the patient to the operating room in order to obtain that definitive control. In patients that have abdominal pelvic penetrating injury, this can be used as a temporary device. I think it's going to depend on the situation. They would still need definitive surgical intervention, but this can be used again to provide for temporary hemorrhagic control. Extremities, it is currently not indicated for patients that are bleeding from their extremities. Again, you would employ ATLS protocol as well as a tourniquet. So here are the zones for placement of the REBOA device. Zone 1, 2, and 3. The two zones that we're employing the device on for hemorrhagic patients is going to be primarily zone 1 and zone 3. For patients that have bleeding in their abdominal cavity, you want to place it in zone 1. In patients that have what you suspect possible hemorrhage from the pelvis, you want to place it in zone 3. And how do you tell if you're in zone 1 or zone 3? You would measure out, and this will be part of the hands-on tutorial with the model. You want to measure out 46 centimeters in order to approximate zone 1, 28 centimeters to approximate zone 3. Also, the instructor will go over using a rough guide to place it in those specific zones. This is what comes in the kit. You have a 5 French micropuncture kit. This is the 7 French catheter with a sheath in order to place your REBOA catheter. And here you have the REBOA catheter with the balloon. So access, you're going to be going into the common femoral artery. Most of the time you can access it using sterile Seldinger technique. However, there are times where in patients that are in extremis with a very low blood pressure or non-existent blood pressure, you may have to perform a cut down in order to access the vessel and then place your needle and then your sheath and introducer in order to deploy your REBOA device. Best practices in placing the REBOA. Ideally, once you know that a patient is coming in potential traumatic hemorrhagic shock, you want to get everything set up. You want to ask for an A-line kit to be available immediately prior to the patient's arrival. You want to make sure that all the equipment is available for the REBOA so that when the patient is there and you have access, you can easily open up the REBOA and thread your catheter through and deploy it as quickly as possible. So in most of these patients, the first step is gaining that arterial access. One of the big benefits with the REBOA in patients that are marginal in terms of their blood pressure, placing a femoral arc line is what we normally do in terms of placing catheters for monitoring in patients that are in hemorrhagic shock. You do not have to place the REBOA. If the patient improves with either fluid or blood products, then you can keep the femoral artery line in there and continue to monitor their blood pressure. You don't have to deploy the REBOA. However, in any patient that comes in that has any questionable hemodynamic status, placing in that femoral arc line kit is the first step in placing the REBOA. And once you have that access, it's fairly quick to place your REBOA device and deploy the balloon. So in other words, this can be a gradual stepwise process in the management of patients of hemorrhagic shock as opposed to some of the surgical options for management of hemorrhagic shock. The use of an ultrasound or fluoroscopy after you've placed the balloon. The ultrasound is useful for initially getting access. X-rays should be available in order to confirm positioning in the zone that you want the balloon to be deployed. And then finally, making sure that the catheter is secured. It seems fairly obvious, but in the heat of the moment, sometimes the catheter is not appropriately secured to the patient. You could be transferring the patient to the interventional radiology lab into CT or OR. That means a lot of movement of the patient. If that REBOA device gets dislodged, that could have consequences to the patient's hemorrhagic status. Pitfalls, leaving in the 7 French sheath for an extended period of time. If you need further monitoring and you have the sheath in for the REBOA, usually after the patient has been stabilized and we have definitive control, we then remove the sheath and we can put in a femoral arc line in the contralateral femoral artery. Some of the other pitfalls, inflating the balloon. Once you see any changes in the waveform, once the blood pressure starts to increase, you want to stop placing any further, you want to stop inflating that balloon any further because there could be damage to the vascular wall. Confirming placement, we talked about having an X-ray in order to confirm the zone that you're in so that you know it's properly placed, as opposed to being in the iliac artery or in zone 2, which could cause issues in terms of ischemia to the kidney. And then balloon inflation time. Again, this is a temporary measure. While the balloon is occluding the aorta, there is no blood flow distal to the aorta, and therefore the clock has been started for ischemic time. And you need to get definitive control in order to reperfuse the lower torso and lower extremities. For zone 1, the guidelines are less than 30 minutes in order to deflate the balloon. In zone 3, guidelines are approximately 60 minutes to getting definitive surgical control and deflating or stopping the occlusion of the aorta. Again, you want to make sure that the REBOA catheter is secured to the patient prior to transferring to the patient to another bed or over to IR or the operating room. So potential complications, the main complications that we have seen from the REBOA, vascular injuries where the REBOA has been blown up in the iliac artery and caused dissection or even rupture. That's why it is important for once you see a change in the waveform, that you do not hyperinflate the balloon to cause injury to the vessel, and two, to get the x-ray in order to confirm positioning of the REBOA balloon in the correct place in the vessel anatomy. Prolonged ischemic time. Again, once you've occluded the aorta, you want to make sure that you are mobilizing the appropriate teams and services in order to get definitive surgical control or interventional radiological control of any bleeding. The longer that the balloon is up, the more ischemic time and potential complications from the ischemia. Further discussion on the REBOA. Finding out as to what the clear indications for REBOA use are. I think we have a pretty good algorithm as to the patients that we can currently use the REBOA device. It's primarily going to be on traumatic patients with hemorrhagic shock, patients that have chest injuries, whether it be blunt or penetrating. Those usually require intervention from a surgical standpoint due to the possibility that if there's injury to the aorta in the chest, blowing up the balloon or placing the balloon could exacerbate or worsen the patient's condition and cause further injury to the aorta if it's already injured from the traumatic mechanism. REBOA versus resuscitative thoracotomy. Is this going to take the place of resuscitative thoracotomy? Well, there is the potential that it could. Resuscitative thoracotomy takes a fair amount of experience. There's a high mortality with resuscitative thoracotomy. There can also be risks to the providers that are performing the resuscitative thoracotomy, including transmission of infection, injury getting into the chest. This procedure allows you to perform what we'd be doing in a resuscitative thoracotomy in terms of cross-clamping the aorta. And in the right hands, experienced hands, you could potentially occlude the aorta faster than you could get into the chest and cross-clamp the aorta. It does not allow you to perform any hemorrhage control while you're in the chest. It does not allow you to control any cardiac tamponade or perform cardiac massage. However, one of the big benefits to the REBOA device is that you could be occluding the aorta and you can continue with chest compressions and CPR, which you are unable to do with the resuscitative thoracotomy. When you are opening up the chest, there is a period of time where you have to stop chest compressions. And the time that you're no longer causing compression to the heart could be many minutes where you're no longer effectively pumping the heart until you get in there and you can perform cardiac massage. With the REBOA, you can continue with CPR while occluding the aorta and providing for effective perfusion of the brain as well as the heart, and not having to stop any compressions while you've blown up the balloon. This may at some point, and already I think for many patients that have low blood pressure and have not arrested, this may be the new standard of care in terms of getting temporary hemorrhage control and resuscitating trauma patients. For emergent laparotomy, this can be used if you have a patient that has a bleeding spleen or liver. It buys you time so that you can resuscitate the patient, give the patient blood. This may be an effective tool in terms of temporizing the patient while you're getting your services in, which could be interventional radiology, and even at level 1 trauma centers, it may take up to an hour for them to get in-house and get control of the bleeding for a solid organ patient. And of course, with a bleeding spleen, we can always go in with an XLAP and get hemorrhage control. With liver injuries, with retroperitoneal injuries, that is a little bit more difficult to get control of from a surgical standpoint. Using the REBOA early on in resuscitation and management in the patient not only would allow for temporizing of the hemorrhagic shock, but would also allow for imaging studies to be done while you're waiting for the appropriate services to come into the hospital. Pre-hospital REBOA. There are some level 1 trauma centers that are sending out their trauma physicians to the site and using the REBOA pre-hospital in order to obtain temporary hemorrhage control and resuscitating the patient prior to getting to the emergency department in the hospital. This may potentially be a life-saving maneuver for patients that are in extremis and we do not have definitive surgical care at the site. So these are kind of the questions for further discussion. From my experience, I've used the REBOA several times, and I have found that it is incredibly useful in patients that are in hemorrhagic shock. I've used them primarily on patients with pelvic injuries. With those injuries, I've been able to temporize any blood loss. I've been able to continue resuscitation until we could get them to interventional radiology or to the operating room to control the bleeding. I do believe that it is a life-saving device, and I'm hoping that we can all become experienced in the use and the utilization and indications of this device so that we can employ it to saving more trauma patients here at Lutheran Medical Center. The next part of this lecture series is going to be the hands-on model. I'm hoping that all of you will have some exposure to the model and placing the catheter. It is fairly facile once you've done it a couple of times. However, having placed it and deploying the balloon is, I think, incredibly useful when the time comes where you have a patient that meets the indications to be placing the REBOA device. Thank you very much.